Thank you, Liz, and hello from Pittsburgh, everyone. We look forward to a couple hours of a good, solid presentation on integrated treatment of co-occurring disorders. If you look at the objectives, what we want to do is give a brief overview of some of the challenges facing patients, families, and clinicians or providers, prevalence of co-occurring disorders, some of the variable patterns of co-occurring disorders, and the effects. We'll also talk about assessment strategies and spend most of the time on integrated treatment, looking at psychosocial treatments, pharmacological treatments, treatment and recovery issues. We'll get into some of the clinical details as we go along. And these would be relevant both to individual as well as group treatment. Just some background, we started our first co-occurring programs in the 1980s, so we were really one of the first in the country to start integrated treatment and be licensed both by mental health and drug and alcohol. We were also one of the first in the country to write a book for clinicians on the treatment of co-occurring disorders, and Dr. Howard Moss, a psychiatrist who works with NIDA, is the co-author of that, and that's been used in a lot of programs around the country. So we've been involved in this area for quite a few decades. So let's start by looking at some of the challenges that face the different groups related to co-occurring disorders. And we'll start from the point of view of the patients. The big issue for, and I think this is true for a lot of mental health patients or addicted patients, but more so for the co-occurring patients, engaging in treatment and complying with the plan, that's a major issue. You have higher rates of failure to enter treatment or stick with treatment. We'll talk more about that as we go along. These folks also have issues related to motivation to change as well. They tend to struggle more than people with a single disorder. One of the big issues is helping these individuals use the appropriate level of care. You have, sometimes you have high rates of use of the higher level of care like hospital, psychiatric hospital, detoxification, rehab. Not that that's not needed, it's needed in a number of cases, but it's easy for some clients with co-occurring disorders to always go to the highest level of care when they have an episode of illness. You also have stigma issues, and you have negativity around folks with co-occurring. And if you look at, a good example would be if you have someone with schizophrenia and they go to the emergency room because they got psychotic and they got sick, you'll have a more openness. However, if you have someone who has whatever kind of psychiatric illness with an addiction go to the emergency room, you're going to have more negativity and stigma associated with that. And we want to keep that in mind in terms of understanding these consumers or clients. Also, another challenge is to do the work of recovery. We believe that people get better if they use recovery skills to manage their disorders. And that's an important issue, teaching skills to manage disorders, regardless of what the combination is. And related to that is developing and using a support system. People that have a good support system in life do better. Clients with any kind of disorder, including co-occurring disorder, if they use a support system, they're going to have a better recovery. Again, that's easier said than done because you have a number of clients who don't have the skills or don't use their active support systems, and that'll be one of the clinical issues we address later on. We did a quality assessment survey a couple years ago with 168 patients, and we asked them what were some of the challenges they faced. And if you look at the issues on this slide here, this gets into the nuts and bolts issues of recovery. And a lot of these are relevant to different kinds of disorders, including addiction as well as co-occurring disorders. But if you look at the first couple, what's real clear is that the number one issue is that a large group of clients identify is, how do I manage my emotions? How do I deal with my feelings? And the ones they identify most are what you would expect, which are the issues around anxiety, depression, anger, boredom, grief, guilt and shame, and these sorts of things that are common with addiction and many psychiatric disorders. The second and third speak to relationship issues. And actually, if you look at the relapse literature, those of you who attended the relapse seminar a couple months ago that Dennis Donovan and I did, that two of the major factors in relapse is people not being able to manage their emotions. They don't use the skills, or they have problems in interpersonal relationships, or they don't know how to refuse offers to use substances. So these interpersonal issues and emotional issues are the top two challenges identified by many clients. And the other issues are what you would expect. You always have lifestyle issues and life skill issues and issues related to how does one think about one's anxiety or one's depression or one's bipolar or one's alcoholism. You have psychological issues such as denial or motivation, things of that nature. So from the point of view of the clients, these are what they see as their major challenges. And the good news about that is these are pretty consistent with what we know from clinical experience and research as well. Now, another perspective that's very important is we have to think about these disorders vis-a-vis the family. So we want to look at what are the challenges for families. And one is, how do they support the co-occurring members' recovery? How do you get them to focus on the family and individual members to focus on themselves? Reducing enabling behaviors, and these are done with good intentions. These are done with the intention of helping the person with the disorders, but they lead to negative outcomes. Managing their emotional reactions. You know, there are studies after studies of family members with a person with a psychiatric illness and addiction or both that show there's a tremendous emotional burden experienced by family members as well. And we want to keep that in mind as we work with these folks. Getting families to take care of themselves, easier said than done. We want to get families to focus on themselves, and if they have children, focus on the children, how they've been affected by the disorders. And very importantly, and I think this is true for any disease, whether it's a medical disease, psychiatric, or addiction, preparing for setbacks, because all these disorders are characterized by rates of relapse or recurrence. It's not a negative thing, but they come part and parcel with different diseases. Now, from the point of view of us, the caregivers and service delivery systems, a couple things we wanted to mention. One is we have to convey helpful attitudes to patients and families. We got to, not be negative, not be stigmatizing, not be judgmental. And I've always pointed this out for years. I don't care what your discipline is. The more you can understand disorders from the inside out, what is the subjective burden? What's it like to have schizophrenia and be a cocaine addict? What's it like to be someone who has bipolar illness and alcoholism, or whatever the combination is? What does that feel like? How does that affect one's sense of self? Also, and this is evident in the previous slide, think family, not just patient. You want to think in terms of family systems. Illnesses do not happen in a vacuum. They often occur within the context of the family system. And very importantly, and Dr. Duane and I have, and many in the Clinical Trials Network, in fact, one of the two objectives in the Clinical Trials Network is to really promote the use of evidence-based practices, whether it be psychosocial, medications, or combined. The other challenges is to reduce the use of more costly inpatient residential services, have different levels. And what we have found is that if you have more ambulatory programs like different levels of partial hospital or intensive outpatient, it may be 3 to 5 to 7 days a week, they can be used in lieu of hospitalization in some cases, as well as a step down from higher level of care. You really need a full continuum to help these patients. Facilitate linkages with mutual support programs. All the research on 12-step programs show that when people get actively engaged in these programs, they do better. And the other thing is we definitely have to work as teams. I don't think any one person can take care of these folks because of the different disorders they have. Now I'm going to turn this over to Dr. Duane. He will talk a little bit about the prevalence and some of the effects and patterns of disorders.
Hi, everybody. Okay, first, in terms of the prevalence, obviously it's very important to get some sense here of what really the extent of the problem is in a sense, in different settings and with different populations, with different patients with different psychiatric diagnoses, the prevalence of substance use disorders, and the other way around, with patients who have substance use disorders, how often do we see psychiatric disorders happening? Two major studies that I will focus on: the epidemiological catchment area study, the ACAS study. As we know, in terms of the lifetime prevalence of substance use disorders, we have the percentage of 16.4%. But if we look at patients who have a history of a drug use diagnosis, almost 1 out of 2 people, 53%, if a little bit more than 1 out of 2 people in a way, have some sort of a psychiatric diagnosis. And if we look from the alcohol use disorders, we have close to 37% of those who have alcohol use disorder have some psychiatric disorder. So this is really, the prevalence is really extremely high in the context of patients who have substance use disorders. If we look at it from the National Co-morbidity study, we have over 10 million people have dual disorders, what we call them, obviously, the co-occurring disorders. And if we look from the other way around, as I mentioned earlier, is patients with substance use, 1 out of 2 has a psychiatric diagnosis. Here it's almost also 1 out of 2 people who have a psychiatric disorder have a substance use disorder. And more than even 50%, close to even 66% of patients who have a substance use disorder have a psychiatric disorder. So the whole point of it here is that we can take the message that we can take from this is that there is a high prevalence of psychiatric disorders in patients who have substance use disorders, and the other way around. Patients who have substance use disorders have high prevalence of comorbid psychiatric disorder. The main psychiatric disorders where we see the highest prevalence of substance use disorders are particularly bipolar disorder and schizophrenia, and also the personality disorders, particularly the antisocial and borderline personality disorders. But I'll tell you the number one, in a sense, is the bipolar disorder. And also we see significant rates of co-occurring disorder in patients who have anxiety disorders and major depressive disorders, and even other anxiety disorders. When we talk about anxiety disorders, particularly whether we talk about GAD, which is generalized anxiety disorders, panic disorder, and we see a lot of patients with alcohol use disorders within that context. Always keeping in mind that most patients that we see have polysubstance dependence, and most patients that we see that have co-occurring psychiatric disorder have more than one or two diagnoses. So which would make it really much more really complicated when it comes to the management of these patients who have multiple psychiatric diagnoses as well as abusing multiple substances. In terms of the patterns of the dual disorders, and this is really extremely important when it comes also to the management of these patients, we have the whole spectrum, the whole continuum. We can see patients with mild substance use disorder and or low, what we call low severity in terms of the substance use disorder, and high severity when it comes to the psychiatric disorder. You could see a lot of patients with severe mental illness, severely disabled because of their schizophrenia or bipolar disorder, and they can use substances on a low level. But also we can see patients who are at really high levels in terms of severity of the substance abuse and the psychiatric disorder. So we have the whole range. And most importantly now in the area of substance abuse, there have been a lot of discussions over really how we define severity and in terms of the substance use, and again, it's really obviously a clinical judgment. Obviously, we also can use a lot of scales that can determine, for us how severe is a substance use disorder. One thing in terms of the psychiatric severity that I would like to mention here is what we define as severe mental illness, which is really particularly defined as in relation to the disability and the functionality of patients who have the illness, which means when you have severe impairment as a result of the mental illness, it fits under the category of severe mental illness. And when we have a severe mental illness associated with a severe substance use disorder, it again makes the treatment much more complicated and much more really also complicated in terms of the medical comorbidities. A lot of the patients who have comorbid severe psychiatric disorders and severe substance use disorders have also very much of a complicated medical picture. In terms of, there has always been the discussion, we've had that discussion in the field of addiction for years now, and you must have heard about this, people always really wondering what came first, whether the substance abuse problem or the psychiatric disorders, and then all these debates about the primary diagnoses versus secondary diagnoses, substance use related psychiatric problems versus non-substance abuse related psychiatric problems. The bottom line here is, and from what we know more and more from the evidence base, is it wouldn't matter much anymore which one came first, the chicken or the egg. What really is most important to understand is how the two disorders, the psychiatric and the substance use disorder, become very much linked to each other. We know clearly that a lot of psychiatric disorders, particularly I'm going to give you the example of bipolar disorder in terms of the axis 1 and antisocial personality disorders, they increase the risk of having a substance use disorder. And also we can look at, most importantly, the interaction that happens, the link that becomes very much problematic is that the axis 1 and the axis 2 psychiatric diagnosis could modify and change the course of the substance use disorder. I can give you the example of the antisocial personality disorder. We have very well established studies of much worse course of substance use disorders who have in patients who have antisocial personality disorders. So in patients who have antisocial personality disorders and substance use disorders, the course of the substance use disorders can be much worse. And these are patients who can become more and more resistant to treatment when it comes to the substance use disorders. So the other way around, a lot of the psychiatric symptoms also can be the result of chronic intoxicating states. Like, for example, we see a lot of patients who have severe drinking problems that could potentially lead to more depressive symptoms, more anxiety symptoms. So in a sense, again, the other way around also is there are a lot of patients who have a tendency to self-medicate psychiatric symptoms using the alcohol, and as a result of having psychiatric symptoms, we have more worsening of the substance use, and so it becomes like a vicious cycle. And obviously, as we know, one of the theories of the co-occurrence of psychiatric disorder and substance use disorder is the self-medication theory, but also it's really more what we call the bidirectionality, which is when we have the two disorders together, they start feeding into each other. And also in terms of really understanding that patients who are chronically using substances, as a result of that, we can see patients having psychiatric symptoms. For example, chronic use of stimulants, whether methamphetamine or cocaine, could lead in some patients to the development of psychotic symptoms and or severe depressive symptoms. And what I mentioned earlier about the importance of understanding that the connection between the psychiatric disorders and psychiatric symptoms and substance use behaviors is that they become very much linked to each other, so it wouldn't matter much which one really came first, which really points to the importance of treating the two conditions in an integrated way, which we're going to talk about a little bit more later. And particularly if we look at patients who have the co-occurring disorders, and which would make the management of them much more really challenging and problematic, is that we have studies that have demonstrated that these patients' problems are really in a way much worse than in patients who have a single diagnosis. We have much more obviously severe financial problems, psychosocial problems such as unstable housing, the homelessness. We see significant challenges in adherence to treatment as well as medications. We have high rates of relapse, utilization of psychiatric services and emergency rooms, hospitals, multiple hospitalizations. Obviously, as a result of that, we have highest costs for services received. And we'll talk about how treatment can change these things. And obviously, these are patients who are at higher risk for engaging in violent behaviors and having legal problems, being incarcerated, and also particularly the increased rates of suicide, as well as the impact on families and concerned significant others. And not to forget what I mentioned earlier, the medical comorbidities that are much higher, particularly we'll talk about the STDs and HIV and Hep C as well as Hep B. The studies that we've done at Western Psychiatric Institute and Clinic, looking at basically the co-occurring patients, and that in a way confirmed a lot of the earlier studies that were done about the higher rates of suicide as well as homicidal behaviors, and particularly, and Dr. Daly mentioned that early on, which is a huge challenge in patients who have co-occurring disorders, is the engagement in treatment, the treatment entry aspect. And yes, I think we would like people to get engaged in treatment. I think the biggest challenge is to keep them in treatment. And as we know very well, if what really is going to predict in a way positive outcome is the duration of care. Staying in treatment is fundamentally important for patients who have addiction, and particularly for patients who have co-occurring disorders. And as I mentioned earlier, also keeping always in mind the higher rates of HIV as well as Hep C in that population that could complicate treatment. This is a slide that shows the medical complications, HIV and Hep B and Hep C, and it gives you an idea about really the high seroprevalence rates in patients who have severe mental illness. You know, if we're looking at HIV, we have 3 times higher chance of having HIV, twice higher chance of Hepatitis B, and 2.5 times higher chance of having Hep C. And keeping in mind here that all these, particularly the HIV and Hep C, they by themselves could contribute to a lot of the psychiatric manifestations as well as the cognitive disorders on top of what the patients are really struggling with. And here, very quickly also, to really give you an idea about how all these disorders become very much intertwined, and it points to the importance of really working on addressing all these disorders in an integrated fashion. And I know we're going to keep talking, we're going to talk about it more and more in details. It's more introducing you to the idea of the integration of treatment does not just involve integrating treatment of the substance use disorders and the severe mental illness and psychiatric disorders. It's also integrating the medical treatment there. Now the next slide would review the screening and the assessment. Obviously, we have an idea now that it's very highly prevalent in the context of substance use disorder to see patients with co-occurring psychiatric disorders and vice versa, the other way around. So in terms of fundamentally in any sort of settings, whether we're seeing patients in the psychiatric settings or in substance abuse setting or in a dual settings, the screening is extremely important, always keeping in mind that screening for substance use is really extremely important, and there are obviously different ways of doing it, whether we want to use some particular scales or we want to use some particular or use the clinical assessment itself. And most importantly, as a result of evaluating where the severity of the substance use disorder and the psychiatric disorder would help us better define the treatment planning, and which will obviously should address the two disorders. And most importantly, as a result of that, the treatment planning needs to be always modified based on how patients are progressing in terms of their treatment and the outcome. And this should be very flexible, because patients are not going to be static. Patients can do very well in terms of their psychiatric symptoms, but they can still struggle with substance use. So we need to always be very much vigilant about getting an understanding of where they are at any point in time, particularly in terms of their readiness for change for the psychiatric disorder or for the substance use, because at one time they can be very much highly motivated to stop using, other times they are not as motivated. So obviously modifying the treatment planning is at any point in time, and reviewing it with the patient, working collaboratively with the patient is an extremely important part of the treatment. Now the next one is in terms of how we approach the assessment. And as I mentioned, there are different ways of doing that, and there are different questionnaires that could be used. There are also the clinical interview that I believe is extremely crucial, particularly in initially establishing therapeutic alliance with the patient and starting to explore and elicit the substance use history. And always important to keep in mind that involving family member and concerned significant others, and I keep pointing to the word concerned significant others because it's always identifying the patients, the family members or the significant others that the patients define as a part of their support network. And because we know that there are some family members that could not be very much supportive and could potentially be not helpful in the process of understanding the patient, or could be potentially detrimental, throughout the process. So again, in terms of the scales and the questionnaires, there are a lot of scales. We don't have much time to go through into the details here, but obviously there are some scales that are used for the substance use, for the screening for the substance use, as well as scales for the screening of psychiatric disorders. Always remembering, and this is extremely important to keep in mind, as a part of the screening and the assessment of the patients who have co-occurring disorders or addictions, is the use of the urine drug screens, and that is an important part of the process. Again, used in a therapeutic way, used as a way to guide the treatment planning, not used in a way to really tell patients that here we go, we caught you here, and we're going to punish you. So this is extremely important to always present to the patient the importance of the urine drug screen as a way to monitor and to progress in treatment, and as an objective measure also, because there are a lot of patients, particularly patients with psychotic disorder and schizophrenia, have a tendency to really not be forthcoming about their substance use, and sometimes what we see is worsening of psychotic symptoms, and we can't understand because they are taking their medications and they were doing very well and they were stable, and then we see out of the blue worsening of the psychiatric symptoms, and when we check the urine drug screen, we find out that they had been either smoking pot or using cocaine that could be potentially contributing to the worsening of the psychotic symptoms. So the areas of assessments, fundamentally, when we're talking, what we're talking about, obviously the substance use and psychiatric disorders, we need to always look at the full spectrum of the medical aspects, the family, psychosocial, interpersonal, the spiritual, financial, legal, occupational. So we talk about all areas of recovery that need to be evaluated. And most fundamentally is the motivation for change. It's the readiness for change. And the readiness for change could be here addressed for the substance use itself and for the psychiatric disorders. We've seen a lot of patients who would come in to see us who have comorbid disorders. They are not much really motivated to address their substance use, or they see their top priority is more they're addressing psychiatric disorders or vice versa. So we need to always get some sense of where they are in terms of the readiness for change and really meeting the patients where they are, and always really getting some sense of where they are in terms of their understanding of what recovery is, what it takes to start the work of recovery. And you'll be surprised how many patients that you see are not necessarily aware or really very much knowledgeable about the whole process of recovery and what sort of work they would need to do. And I think it's a big part of what we really work with the patients on is the psychoeducational piece of really introducing them to that process and helping them understand it better. And the huge also issue, in particular in patients with the co-occurring disorders, is adherence to treatment, as well as to the medication, if they are on any medications, and also that the risks of relapse that could happen, relapse on the psychiatric disorders and relapse on the substance use disorders. So, and so this is really an extremely important part of the assessment, and also always remembering to evaluate the longest period of time patients have been in recovery and the longest period of time when the patients were completely free of psychiatric symptoms, when they are in remission in terms of their psychiatric symptoms. And fundamentally talking about all these issues is getting an understanding from the patients themselves what their quality of life has been like and how they define it, and how their work on the recovery would potentially affect their quality of life.
Okay, we've been together a half an hour, so let's stop for a minute or two, or at least a few minutes. If you have any questions, you can call in, or you can type in a question and we can look at it on the internet. So let's just take a few minutes, see if you have any questions related to the background of the assessment.
So if you have a question, you can press *1 and the operator will open up your line in turn. Dr. Daly, I go ahead and proceed. I encourage anybody, if you come up with a question, you can go ahead and press *1 and we'll take your call.
Okay. Okay, the next section we want to get into is treatment of co-occurring disorders. Talk briefly about stages of change, principles of treatment, and integrated treatment, so that we can sort of set the foundation before we get into some of the more specific clinical issues. And there are different models of stages of change or phases of treatment, but we use this slide to point out some of the differences. And I think the list on the left for addiction, a lot of that is also applicable to mental health disorders as well. You have people that, they're not sure if they have a depression or they have a psychiatric illness. They're not sure they want to change. We see that with addiction a lot, but you also see that with mental health disorders. But I think the field of mental health has offered some very good ways of looking at phases of treatment. And the model we use is used with a depression and bipolar illness, where you have the acute phase where you deal with the current symptoms of the disorder and you continue treatment so if you're treating depression and people are doing better, they're stabilizing from the acute phase, you continue the treatment. And what this would mean, for example, for a single episode of depression, someone who's had their first episode of major clinical depression, the continuation treatment would probably last several months, maybe up to a year after the acute phase, especially if they're on medications. That even if they're symptom-free, you would continue the medicine. If they have a chronic form or recurrent form of major depressive illness, for example, they would go into the maintenance phase. Now, as Dr. DeWahy had mentioned, you have many manifestations of disorders in different degrees of severity. And you do have the severe mental illness, and these are lifelong conditions, but you have other people that may have one episode and that's all they have, or two episodes and that's all they have. So everyone doesn't need to be in the maintenance phase of treatment. This is more for recurrent conditions or for chronic conditions, so you want to keep that in mind. And the thinking is that if people get active treatment in the maintenance phase, and active treatment might be checking with the therapist every couple months and or continuing medications, what they find is that with many disorders, and a good example would be depressive illness, is that you reduce the risk of future recurrence by having people in maintenance treatment, that it is a chronic, lifelong disorder for many people. Now, if you look at NIDA's Principles of Drug Addiction Treatment, it came out originally in 1999, and a couple points that are important, I think, these are very relevant to the co-occurring population. One is you need time in treatment. You can't help people if you don't keep them in treatment. Also, counseling and medication, that combination of treatment is very important. People need both counseling and they need medications. Everyone doesn't need medicines, but many do, especially the ones with the more chronic or severe manifestations of psychiatric illness. And NIDA was advocating integrated treatment for co-occurring a long time ago, which is good. And again, the idea here is that you want to figure out how to treat both types of disorders in an integrated fashion at the same time. And the other point I want to mention here is the last point highlighted, 13, which is recovery. We believe strongly in recovery that a major goal of treatment is to get people engaged in recovery where they can learn to manage their own illness over time. And one of the best ways of doing that is to engage in mutual support programs. It might be AANA, it might be Dual Recovery Anonymous, Double Recovery, it might be a mental health support group or some combination. Now, when we talk about integrated treatment, the ideal is to treat the combination disorders in the same place by the same treatment team when possible. You can't always do this because people go into different systems. Now, for those of you in an addiction treatment program, the challenge you have is to integrate mental health interventions. So, for example, if you have someone with alcoholism and clinical depression and you use the CBT approach for the addiction, you can adapt that and you can integrate CBT interventions for the depression as well. But the point is, it's important for addiction professionals to have some knowledge and experience with mental health interventions they can integrate into their work. The same holds true for mental health clinicians. Integrate addiction interventions to what you do. Now, I've been around for a number of decades. I started out in mental health. I went to addiction, then I went into co-occurring. So I've been in a number of different treatment programs and systems over the years. And my general observation is it's been a bit harder for the mental health side to integrate the addiction interventions. There's been a tendency to want to have the addiction people do that. But the reality is if you work in a psychiatric hospital or a mental health outpatient clinic, that a significant number of your patients will have substance use disorders, whether they were identified as such upon referral. And as you recall, Dr. DeWahy had gone over the high prevalence rates. Now, the focus of treatment depends on what are the current symptoms or problems. It may be more on one type of disorder than the other. It doesn't mean a 50-50 balance. It's going to vary with patient. You know, you might have a good clinical example would be a nurse who came in with depression, and she was fairly stable with the depression and needed to focus more on the alcoholism. Or I've seen cases where people have been fairly stable with the addiction and needed to focus more on the mood disorder or the anxiety disorder. So, again, you want to focus on what are the current symptoms and major issues with the given patient. And even if you're doing private practice, when you're sitting in your office, you can provide integrated services. And what this means is you focus on both sets of problems. Now, at Western Psych, as I mentioned before, we've been doing this work for a couple of decades, and we started in the late 80s. And a number of our colleagues have done we've done a number of research studies, done a number of quality improvement approaches and so forth. And some of this has dealt with specific disorders like bipolar illness or depression combined with substance use disorders, chronic mental illness, which is mainly schizophrenia and substance use disorders, or any combination of disorders as well. And what you'll see when I talk in a few minutes about some of the different models, some will focus on a given disorder, whereas others will be more general. They may focus on any kind of combination. And so if you look at the literature, you see, there's a whole group of folks, Ken Minkoff, who's a friend and colleague for many years, and Robert Drake, Kim User from Dartmouth. They've done a lot of excellent work on chronic mental illness and substance use disorders. They have treatment manuals. In fact, they did the only clinical trial on family treatment of co-occurrent disorders. There's only been one clinical trial, one pilot study and one clinical trial that's been done with their group. Then you have others. You have Robert Lieberman from UCLA, who's done a lot of work on social skills training with schizophrenia. And he and others have looked at how do you treat people with schizophrenia combined with substance use disorders. And here are a couple of folks from Richard Rosenthal from New York, Doug Zadonis from New Jersey. You have Marsha Linehan, who actually in her initial DBT manual didn't focus a lot on substance use disorders, but they realized that since you have high rates of this disorder among folks with borderline disorders, you have to use interventions that focus on the addiction as well as the borderline disorder. In fact, I had a talk with her probably about 15 years ago because I believe a lot of the areas of intervention, focusing on interpersonal effectiveness and emotional regulation, they're very similar to what we try to teach patients with addiction. So actually, if you look at some of these models, there's a lot of overlap with what we teach people who have psychiatric illness as well as addiction. Then we have folks within the CTN, Lisa Novowitz, we've done, I think there's a Seeking Safety program. Kathleen Brady from South Carolina, they've done a lot of work on PTSD, trauma, and substance use disorders. A good friend and colleague who I worked with for about 15 years, Isan Saloom, who's with the Florida node. He and Roger Weiss from Harvard, they've done some of the, I think, the most significant research on bipolar illness combined with substance use disorders. And here are just some resources to be aware of. And I just realized that we will put together a bibliography and send it to you over the next few days. We'll send it to Liz and get it out to you, just so you have some of the references. But I wanted to point this out because what's interesting is if you look at some of these models, a lot of them have moved away from an individual model to using a lot of group work. And this is just one that they look at groups in terms of different types of groups. Some of the early recovery groups where you try to persuade people they have a problem and get engaged in treatment, social skills, self-help, and so forth. And this model also includes focus on family issues as well. Then there's a lot of educational handouts and instruments. There actually is I believe in the back of this manual you have a lot of handouts that you can reproduce for patients just to give them the information on whatever the topic is. And Roger Weiss, who is the PI up in Harvard in the northern New England node, Roger and I have worked together for a couple decades, and he has done some very interesting work in integrated group therapy for bipolar disorder. And I'm happy to say that his new book just came out a few months ago. It's been used in several trials. That it's a number of structured group sessions plus sessions with a physician. And they've compared this to parallel treatment where you get mental health treatment from one person and you get addiction treatment in a group. And you tend to do better if you have the integrated treatment in terms of mood, substance use, and overall it's better than the control condition. Although the control condition also works very well, but this works better. Seeking Safety, a lot of you are familiar with this from some of the previous clinical trials in our network. Again, this is up to 25 sessions, and some of the topics are PTSD, triggers, recovery. And what I like about Lisa's model is that, a lot of these, you understand the nuts and bolts topics like the triggers and recovery and substance use, but, you get into what we would consider spiritual issues such as meaning in life. That's very important because I think, from thinking as a clinician, not a researcher, that the patients who have a sense of connectedness and meaning do better than those who don't. And a lot of people in the 12-step programs would say that that's a spiritual issue they try to attempt in the 12-step work. Here's a more recent version of the DBT, dialectical behavior therapy, and they include a chapter on substance dependence, which is very good. In fact, some of the early work, when they did a manual on substance abuse among this, referenced some of the work we did in the Cocaine Collaborative in the 1990s. So they were looking at how do you integrate some of the drug and alcohol addiction interventions into this mental health model. And then we started this in the late 80s, early 90s, and this is on the 3rd edition, and we have a patient workbook that goes with this. And what we did is this wasn't for any one disorder. we took all the literature and we took our experience, we took what we know from the different studies of mental health, addiction, and co-occurring disorders, and we put together an integrated model. And we focus a lot on, we have the background where you give the overview, you do supervision, assessment, and so forth, but we focus on the family, and we have a curriculum for 43 structured group sessions so that you can teach patients. You can use a psychoed format where you can teach them a number of topics related to, some may relate to one disorder, some may relate to both disorders. And what's missing here too is there's a focus on therapy groups as well, because what we have found in our clinical programs, whether they be inpatient, residential, partial hospital, or intensive outpatient, and patients will tell you they like this too, is when you use a combination of groups, the structured recovery groups with a curriculum, and the open-ended therapy groups where they can talk about whatever bothers them or whatever issues they have unique to the group of people, they like that the best. So you really want to have a blend of both. You don't want to use just all structured groups, but you don't want to use all open-ended and unfocused groups as well, a combination. And the SAMHSA has a couple protocols, and some of you are probably familiar with these. They have a pretty extensive summary of the literature on co-occurring disorders in manual number 42. Then they did one on early recovery and depression with substance use disorders, and one on suicidal thoughts and behaviors, and suicidality is a major issue, particularly with some of the disorders, some of the mood disorders and the psychotic disorders. So if you look at bipolar illness, for example, people who are treated well for bipolar illness, the risk of suicide goes down significantly. So and Dr. DeWahey will talk a little bit about the clinical issues related to suicide later. And this is just one. I was involved in some of the writing of this, but this is the good news is some of you who know the SAMHSA manuals, they've begun to be briefer and more user-friendly. And they have a section for clinicians, and they use case histories and where they discuss some of the treatment planning and treatment issues. But they also have a section for administrators and some resources as well. So these are good tools to have available to your clinicians. And what we tend to do is for our clinicians, we tend to give them a lot of resources to help them in their work. Now, Antoine, Dr. Leahy's going to talk a little bit about the research, and here's one of the scientific slides that he found.
Well, I think this is really important here. We've been discussing the integrated treatment, and what I would like to review here with you is particularly why would we keep really insisting on the integrated treatment. And I think one thing to keep in mind is obviously this is the whole really mission of disseminating evidence-based treatment, is that we owe it to our patients and their families to really provide treatments that work, that provide treatments that have been proven to work. And keeping in mind that this is more of an ethical and professional thing, and it's unfortunate that what we end up seeing is that the application of evidence-based has not been really, particularly in the area of addiction or co-occurring disorder, has not been really disseminated. I mean, we're still struggling with figuring out how to really implement it and how to eventually disseminate it also to the healthcare professionals. Anyway, so this is well established, the research on the integrated treatment and versus really what we call the sequential or parallel treatment. We have a well-established data on the fact that if we provide sequential treatment, which means that you start treating, for example, substance use disorders, and then you treat the psychiatric disorders, or parallel treatment when you send somebody for treatment in an addiction program for their substance use and send them to a mental health clinic for the treatment of the psychiatric disorders, the sequential and parallel treatments have been associated with poor outcomes, well-established. And the integrated treatment has been well established in terms of particularly in patients who have severe mental illness with substance use disorders. It's unfortunate that we don't have a lot of studies that have looked at patients who have more of the mild or moderate mental illness with substance use. So we need to work more on that, and particularly in areas where different settings, like primary care settings where patients are seen with mild, let's say, depression with alcohol use disorder. In terms of the integrated treatment, it hasn't been looked at in settings like that, or it hasn't been looked at, for example, in another setting like the, jail settings. So, but anyway, clearly well-established, at least 30 controlled studies that showed that it works way better. It's more effective than the traditional separate treatment, and it leads to better substance abuse outcomes as well as psychiatric symptoms outcome. And we have a clear evidence to the fact that long-term outpatient is more effective than intensive residential or day program. So in terms of the quality improvement initiatives that have been also done and looked at really here at Western Psychiatric Institute and Clinic, we've been very much interested in that because we tried to do whatever we could to really, in a way, inform changes in our practices. And well established also, in a sense, confirmed the studies that have showed that integrated treatment works way better than sequential or parallel treatment, and clearly leads to a significant reduction of psychiatric symptoms as well as reduction of substance use, and particularly, most importantly, as I mentioned earlier, the importance of keeping these patients in treatment, keeping them engaged in treatment, because we know very well that one of the most important positive outcomes of related to substance abuse is the duration of care, as well as obviously the therapeutic alliance. So interestingly also enough that what we've done with also what we call the motivation incentives, which is a continuously management based on reinforcement, clearly significantly increased the attendance, the participation in partial hospital program here. And what is really important is that if we can keep people in treatment, we know that they can do well. You know, as long as they are engaged in treatment, we can do the intervention that we need to do. So this is an important study that has been done here at Western Psych. Dr. Daly was overseeing that study, and it's basically using motivational intervention based on the principles and the spirit of the motivational interviewing, and looking at the cohorts of inpatients. These are patients who have co-occurring disorders. They have severe psychiatric disorders as well as substance use disorders. And the intervention was one focused session, motivational session, and done by the outpatient clinician prior to the hospital discharge. So the whole idea here is basically is to get these patients to engage in treatment. The toughest part for these patients is after they leave the hospital to really make it to the outpatient, to really get into the outpatient. And we know very well if they get into the outpatient initially that we can start doing the work with them and increase the probability and the chance that they stay in treatment. And in fact, what it showed, a single motivational session increased the initial show rate to 63 to 76% from 40.4%. In a sense, that is really very much has such a significance here clinically, because obviously, and as you see from that slide, next slide, is that just one session could make such a huge difference to getting patients engaged in treatment. And as I mentioned, this is the co-occurring populations are patients who struggle significantly, much more than the single populations with engaging in treatment. So here I keep talking about really the data in terms of the integrated treatment. And I want to just really go through briefly here some of the research that has been done. Clearly, as I mentioned, in terms of the abstinence outcomes, integrated treatment does improve the abstinence outcomes. If you look here from the slides, the parallel treatment versus the integrated dual diagnosis treatment, and the yellow is the parallel, and the red is the integrated treatment. As you can see here, the percentage in remission is really much higher over the course of the years for the patients who are in integrated treatment. And this is a very, very interesting study, a fascinating study, in fact, looking at, again, in dual diagnosis study, at really the impact of the integrated treatment on really the arrest and incarcerations. As we know, this is a major problem in patients who have the co-occurring disorders, and we've seen a significant decline as people get treated for dual disorders, recover from substance use, and take a look at really the course, at 36 months, for example, versus 6 months, and the significant decline in the arrest and incarcerations. And here, this is the same study, and looking at really the inpatient versus outpatients. As patients get engaged into treatment, in terms of the median treatment costs, patients who become more and more involved in recovery how we can see them utilizing less the inpatient and even less the outpatient, but the outpatient increase initially more and more once they are in treatment. And obviously the costs decline more for people who are in recovery, the general cost. Inpatient costs significantly decline, as you can see the blue one here, or the violet, whatever, you can see the color there. And there is clearly a shift to more an outpatient, which is the red one here, is that you see people more utilizing the outpatient. And obviously, interestingly enough, also from that study, that showed that the most successful people often start with higher than average treatment costs. So in a sense, getting them into treatment, you're going to really, in a way, save more money down the road. Again, this is another slide that shows the importance of also an overall improvement of the outcomes as a result of the integrated dual diagnosis treatment. And here, another one that is also looks as basically the outcome by treatment condition, but this is also in the populations that have basically psychiatric disorder. This is the group versus the individual. It's basically these are the bipolar. I believe this is a bipolar, population with the substance use, and studied by Dr. Weiss, and looking at clearly, how really look at the 6 months follow-up versus really the end of the treatment, the significance, and clearly the integrated group therapy works much, much, much better than the group drug counseling that just focuses on the addiction itself.
Okay, I want to see if there's any questions here.
Yep.
There's 3 questions.
Dr. Daly?
Yes.
We have a couple questions that have come in.
Okay.
Mm-hmm.
I'm going to go ahead and open up the Q&A feature. I had a question. Are there any composite measures to assess impact for co-occurring disorders?
What?
I'm sorry, say it again, Liz?
Sure. Are there any composite measures to assess impact on functioning for co-occurring disorders? And I would encourage Dr. Trivedi to go ahead and press star 1 if you would like to discuss the topic with the doctors.
Yeah. We've used the addiction severity index, but obviously it's really used for the addiction, but it can also indicate the impact on other areas of functioning that could be also affected by the psychiatric disorders. We did a study here for the depressed alcoholics, and in fact, a part of what we follow up with in terms of the impact of treatment in the study was basically looking at fluoxetine and naltrexone versus fluoxetine and placebo for patients who have depression as well as alcohol use disorders. So we've used the addiction severity index. Obviously now there is a shorter version of it too. I don't believe we have a particular one that really looks at the two, that one specifically for the dual disorders. But obviously the ASI could be really used in that context too.
Yeah, and you could also look at specific disorders. You could look at anxiety, you could look at depression, you could look at schizophrenia and some of the symptoms and changes over time. And the other thing too, and this comes from the Clinical Trials Network Outcomes Task Force, that you also want to look over time at the whole issue of quality of life as well, because that's a good outcome measure to consider when you're working with these folks.
Which is unfortunately has not been in the area of addiction. It has not been really tapped into as much as it should be. But I think now we are really looking more and more at the quality of life also as really one major measure in a sense.
Great, thank you. I have one other question from an Andrea Weiner. How often do you see patients who do not know they have a psychiatric diagnosis but only see their substance use disorder?
Okay, well, that's a really very good question. Unfortunately, I think we see that very often. And the reason is because a lot of patients who have addictions, who have substance use disorders, they've been in a way conditioned or been really told, when they are, particularly in addiction treatment programs, that, well, look, if you stop using, your depression is going to go away or your anxiety symptoms will go away. So a lot of patients come with the belief that, look, all I want to do is really focus on my addiction, and I know my depression, my anxiety would really get better if I just really get clean and sober. And in fact, I think a big part of what the challenge that we deal with all the time, in a way, is to get patients to see that's true, that the addiction and the substance use can worsen their symptoms, but if they have an underlying depression and anxiety, if they are not addressed aggressively, it doesn't really, they cannot improve, and their outcome is not going to be as good. So I think a big part of what we need to do is basically focus on that psychoeducational piece and getting patients to really understand that if they have the psychiatric symptoms, these psychiatric symptoms could be either related to an underlying psychiatric disorder, or it could be also really related to the worsening of could be related to substance use. But again, I mentioned that earlier about the whole concept of understanding the connection is not which one really came first, is more like when the psychiatric symptoms are there with the substance use, they have to be treated aggressively, and because they are become linked to each other. So yes, I mean, it's a really a very important issue, and we deal with this issue on a really regular basis, particularly in addiction treatment programs where there's too much emphasis on the substance use and less emphasis on the psychiatric piece.
Yeah, we had, for years, I used to run an admissions group with one of our program managers, and we have mainly dual diagnosis co-occurring patients, and you would see the whole range. Well, I'm here for depression, I'm here for alcohol, or I'm here because I was told to come here, I don't know what the hell I'm doing here. So we had really a variety of levels of motivation or awareness of one's problems. And I think in terms of time, you can make a contract to meet with someone a couple times to talk about whether it be the drug and alcohol issues and mental health issues, to help them determine if there's a problem, if they want to do anything about it. And that's kind of a way of trying to engage them in treatment, to giving them the option of sticking with you or not sticking with you as well. So, and there's really no time frame.
We'll get to the psychosocial treatments. One thing that to mention here when I work with patients in terms of really also getting them to understand the whole principles of dual recovery. One of the metaphors that have been used originally by the Yale group is the three-legged stool, which is the of dual recovery, which is being clean and sober, adhering to the medication, and adhering to treatment and self-help groups, and 12-step. So when one of these legs is not there, in a sense, we know that the stool is not going to hold. And I think this is one really way of really presenting to the patients, the importance of really the integrated approach.
Okay, we're going to just talk briefly about the need for a continuum of services for co-occurring disorders. And clearly, from what we know from clinical experience and all the research, is you really need a range of psychosocial treatments and services. You need medications, medical services, and very importantly, you need access to mutual support programs as well. So you really need all of these. If you get into some of the details, you need the whole range of hospital, residential, ambulatory, and it goes back to a lot of the research that Dr. Dewey presented, is that long-term ambulatory involvement, outpatient involvement, is the desired approach for the more chronically mentally ill who have substance use disorders, that you have to keep them in a good amount of time to help them achieve stable remission from the substance use disorder and the psychiatric disorder. But you also need crisis intervention services. We have a crisis program here, which is very nice. We have a facility they can go to and stay a few days. They can go to 24/7, and a lot of times that helps people stay out of the hospital or a higher level of care, and then they can connect them with whatever level of care they need. Clearly, therapy or counseling. You also need services, housing, economic, and medical. You have higher rates of problems with economic or money problems. You have more medical problems, as Dr. Dewey pointed out before. Another important program is psychosocial rehabilitation, and ideally a psychosocial rehab would have integrated some focus on the substance use disorders as well. And these are programs that, excuse me, focus on teaching people skills, skills related to the workforce, related to working, job applications, technical skills, interpersonal skills, things like this. You also have disorder-specific therapies for both types of disorders, addiction and mental health. And some you have an overlap. You have So you have a number of therapies that have been used with both types of disorders. Some examples would be cognitive behavioral therapy or interpersonal psychotherapy. As I mentioned before, if you have a specific approach and you're well-grounded in a mental health treatment or an addiction treatment, you can be more effective with these folks if you learn one model from the other type of problem and you integrate that with your work. And then clearly in the last decade or so, the integrated therapies for co-occurring disorders are becoming more important, and you're seeing more of these come up. Now, in terms of the one cohort, the more chronically mentally ill cohort, and this is from the work from the Dartmouth group. As I've mentioned before, they've done a lot of excellent work in this area and done a lot of manuals and have a lot of good resources. They believe that for the chronically mentally ill who have substance use disorders, that you have to have case management. And we believe that's true too. Even folks who don't have chronic mental illness, we think case management is often a very effective service. It can help people get re-engaged till you lose. They can facilitate linkages to community services. And it doesn't matter. It could be medical services. It could be housing. It could be school. It could be anything. Close monitoring of symptoms, of functioning. Definitely treatment that will focus on drug and alcohol issues. Rehabilitation, that can be in psychiatric rehabilitation, addiction rehab, or co-occurring rehab. Unfortunately, rehabilitation, for the most part, is pretty much either addiction or psychiatric, although there are some integrated programs. We happen to have one. And I can tell you from many focus groups I've done for decades with thousands of patients, the biggest criticism they've had in the field of mental health or addiction, if they had co-occurring disorders, is that most programs tend to focus just on one issue and not both issues. And again, we have to get away from that model. We have to focus on the integrated care to maximize the outcome. And then you're going to have people that need help with housing, residential housing, supervised living arrangements. And unfortunately, we still, all of us, deal with a significant population of homeless clients as well. And then medications are a big important part, and Dr. DeWahey will talk about that next. But I do want to point out, and I don't know if it's in here or not, that typically there is no issue with using medications for chronic mental disorders or severe psychiatric disorders. But you do have some clinicians who are a little bit hesitant for certain clients to use medications. I want to give you a brief case example. Saw a depressed young man who was about 28 years old. It was pretty significant major depressive illness. He had been sober for about 9 months, and his clinician, well, he said his clinician didn't believe in medication for alcoholics. Now, I'm a little bit suspect sometimes of what patients tell me, so I said, I better check this out. And lo and behold, I had a great talk with his clinician, a very dedicated addiction therapist, and she told me she didn't believe in medication for alcoholics. This young man would not have gotten well without the medication for his mood disorder. So addiction clinicians have to be open for medications, as do clinicians from the mental health side. The other issue I think that's important is that in the addiction field, we're very good at using opiate replacement therapies, Suboxone or buprenorphine or methadone maintenance for people with multiple episodes of relapse to opiate addiction. But we don't do that with alcoholics, with people with alcoholism. And you have a lot of medicines for alcoholism. So one of the important interventions to help people is to offer the option of medications, particularly for people who meet criteria for alcohol dependence, who have had trouble staying sober. The medications can be very helpful. Now, without further ado, I'll turn it back over to Dr. DeWahey. And we do have, in your handout, we have a nice summary of all the different categories of medications based on the first column will be the type of illness, and then you'll have the type of medications like schizophrenia, typical antipsychotics, atypical antipsychotics, anticonvulsants, and so forth. So this is just a resource for you. And I think we also give you a web page where you can get you can print a booklet on medications for addiction or mental health disorders.
So in terms of the pharmacotherapy, I'm going to go through a couple of slides to really over some really principles or really in a way some concerns about prescribing medications in the context of patients who have co-occurring disorders. And as an addiction psychiatrist, obviously I'm very much aware of the importance of doing that, of really the medication is a big part of the dual recovery process. We still see a lot of physicians that are really very much reluctant to prescribe or don't have much of the knowledge or really the understanding of how prescribing could have an impact on the outcome, or also the concerns about really some sort of psychological issues that, we're going to get our patients to rely too much on the medications, and then they are not going to really see the importance of psychosocial treatments and counseling, which is really not true, because we've seen a lot of patients who understand the importance of the combination of both approaches. And our major part of what we do is to get the patients to see the importance of integrating the medication with the psychosocial treatments. There is always the concern about, I put it in parentheses, the whole thing of enabling. It's like they have to really use the medication, and it's going to really, in a way, instead of using it as a tool, which I always present that to the patients, is really using it as to really looking for some sort of a quick fix, and also there is a big concern that not just among providers, clinicians, or the patients themselves about the medication safety and related issue when they are really taking medications and using on top of it or using whether alcohol or drugs. And the problem is that I always have patients who always ask the question, well, if I end up really drinking, I decide not to take my medications, is it risky to take the medication? And these are all issues that can really always happen. And it's important that we discuss with the patients the fact that yes, there are interactions that can happen between the medications and the substances. At the same time, discontinuing the medication without discussing it with the healthcare practitioner is really not a good decision. So in terms of the other things, in terms of the concerns that I've talked about also with the abuse liability, is like, the medications that we have, the psychotropics that we have, are they abusable? Are there some of them addictive? As we know, the category of the benzodiazepine, that is really a huge one now, and that obviously has the addictive potential. There are two relevant questions that are always looked at is, are these medications in a way rewarding? Do they cause physiological dependence? Do people depend on them? And you have a lot of patients who are really always questioning and wondering about it. And also, particularly, are these medications in a sense sedating? And do they have major side effects that could affect the ability for the patients to function? So these are all very much of a legitimate questions that we need to look at. This is really just to give you a little bit of an idea of some of the psychotropics that we use in patients. Whether there's this concern about the abuse potential, we clearly know from when it comes to the antipsychotics, the mood stabilizers, and some other medications that you see there, like buspirone, which is an anti-anxiety medication, and they have little or very much none, in a sense. I don't want to really eliminate it completely in a way, but there has been the discussion about some medications that can be overused or misused. Some medication that can be misused and overused does not necessarily mean they are abusable or they are addictive in a way. And some medications that we use, for example, the anticholinergics, like I give the example of Cogentin, and some people that has some potential for abuse and addiction. I'm going to give you the example also of some of them, for example, the zolpidem, the modafinil. In fact, it's very much little in terms of the studies that we've seen. The modafinil that is used basically for narcolepsy has been used now. More and more studies that have been looking at the modafinil in the treatment of cocaine dependence. The ones that have a significant potential for abuse is obviously the benzodiazepine, the barbiturates, and the stimulants, that we need to always keep that in mind. So in terms of really, there are some particular medications for some particular disorders. In the main areas that we have medications for substance use disorders are basically alcohol, opioid, and nicotine. Unfortunately, we are still trying to figure out something for the cocaine, and we are really in the very, very early stages of trying to figure out something for the cannabis. and unfortunately there is nothing yet, and we are hopeful that more and more trials will be done to look at that. And obviously there is the pharmacotherapies for any particular psychiatric disorder, whether mood disorder, anxiety disorder, psychotic disorders. One thing I want to mention here as really important, when we have patients who have co-occurring disorders, I'm going to give you the example of patients who have depression, whether it's major depressive disorder or chronic depression, like what we call the dysthymic disorder, and, for example, the alcohol use disorders. There are a lot of studies that have looked at medications, antidepressants, for that population. And unfortunately, very few studies that were placebo-controlled randomized trials. And one thing that we can really say for sure, that we have clear evidence that that supports the efficacy of antidepressants in treating patients who have depression and alcohol abuse or alcohol dependence. And we should always consider using the antidepressants in that populations. And also it's very much similar to patients who have bipolar illness with alcohol use disorder or substance use disorders. There are some medications, some mood stabilizers have looked at treating these populations, particularly the valproic acid, as some people know it as Depakote. As there are earlier studies, in fact, one of the studies we did here, which was placebo control. It's a more a study that looked at adding the valproic acid Depakote to lithium and treatment as usual. And in fact, we have more and more studies now coming out as point to the importance of using the medications in that population. Okay. Very quickly here, I want to go. We talked about the integrating the medical piece, and the three things that I'm going to talk about very, very briefly. I'm going to try to be as quick. Is pain, with the chronic pain, which is a huge comorbidity in patients who have addictions and psychiatric disorder, HIV, as well as Hep C. So here, this slide, just to give you an idea about really the complicated vicious cycle that could happen in patients who have chronic pain and addiction, as well as other psychiatric disorders such as depression, anxiety, and how all these disorders feed into each other and lead to the functional disability, lead to a lot of secondary discomfort. You know, in a sense here, what we're seeing here, really all these disorders very much interacting with each other, which points to the importance of integrating treatment of the medical issues, the chronic pain, the addiction, as well as the psychiatric disorders. When it comes to the HIV and the co-occurring disorders, we have a high prevalence of what we call the triple diagnosis, which is HIV, substance use disorders, and psychiatric disorders. Any sort of setting where you look at whether in substance use disorders, you're going to see a lot of patients who are HIV positive, or in HIV clinics, the primary care clinics, you're going to see a lot of patients who use substances and have other psychiatric disorders, particularly depression. And here we go again. We've talked about the importance of integrating treatment and how much the integrated treatment of all the three disorders. You can imagine how much more complicated it is, and to really integrate the treatment here, and keeping in mind the integrated treatment is going to also improve the medical outcomes in that population. So here quickly, I want to really point out to the importance of the patient-centered approach, and always keeping in mind that this is a population that struggles with a lot of psychosocial issues that could really complicate the treatment. Another one that is a huge one, medical comorbidity in patients who have substance use disorder and psychiatric disorders, is the Hep C. And as you can see here, the high prevalence of substance use disorders, depressive disorders, and anxiety disorders, and always keeping in mind that patients who have also Hep C, they can have also a lot of cognitive disorders and the effects of basically the virus itself. And always keeping in mind, as you've heard, probably a lot of your patients have been now getting treatment for the Hep C, which is the the treatment that can really the interferon treatment that can also by itself complicates the whole picture and leads to a lot of the psychiatric problems. Keeping always in mind that we have treatments that work. Patients who have these complicated medical issues, who have the co-occurring disorders, they can tolerate treatments, and they have to be given the opportunity to be in treatment for their medical issues and not be banned from treatment because they are struggling with substance abuse and psychiatric disorders. And another example here of the importance of the integrated treatment for that co-affected population with HIV, we've seen patients basically who have quadruple diagnosis. We have patients who are HIV positive, Hep C positive with psychiatric disorder and substance use, and fundamentally these patients would require also integrated services for their medical, psychiatric, and substance use problems. And obviously, as Dr. Daly mentioned earlier, the importance of the outreach services and the case management and to really optimize treatment outcomes.
Okay, we can stop here. If you have any questions, we'll see if you want to send any questions in or ask any questions.
Again, if anybody has any questions, press *1 and the operator will open up your line in the order in which it was received. We did get 2 questions that came in on the Q&A feature. The first one is asking, do you have an opinion regarding ASAM certified physicians prescribing for a patient with the co-occurring disorder as opposed to a non-certified physician?
The ASAM? Is this
ASAM certified versus non-ASAM certified?
For physicians? No, I think obviously the ASAM they have a certification to become also boarded in addiction medicine, but there is that usually that would require physicians to be involved in treating patients who have addictions and psychiatric or also co-occurring disorders, demonstrate the experience as well as taking an exam. And so that would really give what we call the certification, ASAM certification, and also the American Board of the Addiction Medicine certification.
Was there another one, Liz?
There was, from Angela. I had a situation where a patient has co-occurring disorder. However, there is a conflict with the patient and the psychiatrist about medication. How do substance clinicians address this client?
Well, I think, that's a tough one because you have no control over outside physicians, but I think you want to use your psychiatric consultant to help you with this, and he or she may have to have a consultation with the physician. And the reality is you're going to get, even within the field of psychiatry, you'll get different opinions about what medication should be used with a specific patient. So I think the best approach is to consult with your program psychiatrist or physician, have them advocate for you, or you can advocate for the patient, but with the understanding that you can't control external physicians, what they're going to prescribe to someone. That doesn't mean you can't talk with patients about the medicines if you have some concern over the medicines. And probably what they're referring to, I would suspect, is something like benzos or pain medications that may be part of their addiction history. I don't know if you have a comment on that, Angela.
Yeah, I think it's really important to have a discussion also with the patient about their behaviors in regards and their understanding of what the medication, the role of the medication in their recovery. I think that's a huge challenge, as Dennis mentioned, is with patients who are on benzodiazepines, particularly this whole idea of, because obviously they do work for anxiety, but obviously it's extremely risky to consider treatment with benzodiazepine in patients who are in active addiction, and that could really have a tendency to either misuse or abuse the medication, or even really put them at higher risk for continuing to use the substances that they have been using from before, in a sense keeping them stuck in that vicious cycle. So I think also most importantly is having the patients advocate for themselves and really be able to really talk very openly, about what they are really expecting from the medications and in terms of their recovery.
Okay, we're going to move to the counseling model. And again, my apologies, we're a little bit behind, but that sometimes happens. And I mentioned we started this in 1980, and we have patients do a lot of work using workbooks and recovery assignments and that sort of thing, and here's just one example. And so the goals of integrated treatment are these. I won't go over them individually, but just a few I want to mention. One is definitely, obviously you have to focus on motivation engagement issues, but the big issue with the clients we work with is coping skills, improving their coping skills, cognitive, affective, interpersonal coping skills. I think that has to be a major focus of treatment. Another major focus has to be looking at what can you do to decrease relapse risk or intervene early in relapse or recurrence, because terms are different in terms of psychiatric illness versus addiction. A big issue is alliance, and your patients want to be heard, not judged. They want to be respected. It's good to have a contract. What are the goals of the patient? What do they want vis-a-vis the depression or the schizophrenia or the drinking or the cocaine use? Helping them accept their disorders. And here you get into telling the story, getting into the details, giving them feedback. Feedback's important. Someone may want to know, well, do I have a clinical depression? And you can go over the symptoms. Do I have an alcohol problem? You go over the symptoms. And clearly, motivational approaches are very helpful. Motivational interviewing, motivational enhancement therapy. So if you look here, those of you have, this is Dr. DeWahey on a horse, if you haven't met him. What do you think? Do you think you look like him?
No.
No, he said he's handsomer than that guy. Okay, we'll give him that. No one is making you do anything you don't want. I'm just trying to say we're all headed for Dodge City and we think you should come along. I think what that conveys is you want to meet patients where they're at and you want to integrate some of these motivational strategies to get them interested in treatment. Now, clearly, the abstinence goal may not be the patients. That's a long-term goal we're looking at, but we want to look at people, help people look at the details. That helps them determine how severe their problem is. You want to look at what are they getting from substances, because you just can't assume everything's negative. And if you look at abstinence, there's two sides, pros and cons. What are the pros and cons? What's a patient going to miss about not using? A lot of examples we can go into. We won't because of time. And then very importantly, what are the effects of drugs and alcohol on the psychiatric disorder, on oneself and family and others? This is where you get into the adverse effects, and that's one of the strategies that you can help people, you can use to help people come to the conclusion about the severity of a problem they're having. Now, in some cases, if people are physically addicted, you have to look at withdrawal symptoms, and there may be times in which you have to facilitate detox. And typically that's done with using withdrawal scales and medications. And we actually have we use detox in our psych units. We have a medical unit. We use ambulatory detox as well. We really have a variety of different strategies we use for different kinds of patients. Now, in terms of medicine, this is just supplements with some of the things Dr. DeWahey said. The goals of therapists and counselors, you need to facilitate assessments. Augmentation therapy, what that means is, if you're working with a patient who has alcoholism and depression and they're on an antidepressant, but they improve by 30%, they're not as good as you'd like to see them, then you talk with them about and with the doctor about maybe they need a second medicine added to that. That's referred to as augmentation therapy in the field of psychiatry. Sometimes more than one medicine is needed. Very importantly, what does it mean if I'm in recovery and taking medicine? And then how do you also want to help your patients anticipate, prepare that people may say, hey, why are you taking that antidepressant? Why are you taking that medicine for schizophrenia? That you will have some people with black and white thinking that truly believe an addicted person should not be using any kind of psychotropic medicine, which is really a shame because I've seen too many people suffer because of that. And then very importantly is if you have a patient on medication, you have to monitor adherence because they're not going to see the physician that often necessarily. They may see you every week or every two. You want to find out, are they using their medicine as prescribed? And you want to get into the specific details because if they're only taking it 40% or 80% of the time, they may not get the maximum effect from it. Education is important. I mean, we all agree on this, and these are just some areas. The process of change, what is recovery? We use the biopsychosocial spiritual framework. Relapse, recovery supports, all these different areas are important as we educate our patients. They need education on disorders. And here's a good example. If you're working with people with a mood disorder, say a depressive illness, what's the difference between major depressive illness, single episode, or recurrent? You want to teach patients this. Or what's the difference between, what's it mean if someone says, oh, yeah, I have dysthymia and major depression? What does that mean? Treatment options. You want to present treatment options. And very importantly, this comes out of the work of Lieberman from UCLA, which I think is a terrific, terrific intervention, which is chronically mentally ill patients who will always have symptoms. The symptom may be anxiety, it may be a hallucination, it may be a delusion. To monitor the persistent symptoms and know at what level they're acceptable and at what level I need a new intervention. Maybe I need to get my medicines changed or go to the hospital or call my doctor or my therapist. So the persistent symptoms, managing persistent symptoms for those with chronic mental illness is a major intervention. And then you also have the issue, you can take this concept and adapt it to addiction as well, because for many people, it really is a relapsing chronic disease that they need 3, 4, 5 episodes of treatment before they settle into a long-term recovery. So they're going to need to learn addiction recovery skills, and those are things like how do you manage cravings, how do you change your lifestyle, how do you refuse offers, things like this. This is a big issue. We won't talk about this much because of time, but cravings and obsessions will bring people down if they don't have a way of paying attention to these, monitoring these, and looking at these over time. And really, there's a variety of strategies that we all teach in programs, how people can think differently or what they can do. But the other thing is there are medicines, many of the medicines, for example, for alcoholics, tend to have a positive effect on reducing the desire, the obsession, the craving to drink alcohol. So you want to consider pharmacologic interventions as well as the behavioral interventions or cognitive interventions as well. Changing thinking, this is one of my favorite quotes, Mark Twain. I'm an old man, I've known many troubles, but most of them never happened. And we know that actually this is where I think CBT has been extremely helpful. There's a lot of CBT literature where they focus on teaching people to change some of their beliefs and some of the ways they think about the world. And this is just one example related to anxiety. You could relate this to, you could take some of these concepts and relate it to different symptoms or different problems as well. But using slogans or self-talk, so if, you may have someone with a generalized anxiety disorder that, anxiety is part of life, I have to accept it. My fear, my anxiety won't last forever, live in the here and now, things like this. You can also look at this in terms of thoughts related to drug and alcohol use, vis-a-vis relapse, like it can't happen to me, I'll never use again, I can control my use. Now, these are just some specific examples. You can go into a lot of other examples related to different disorders. But one of the ways of looking at, and we use worksheets and we use discussions and we use the dry erase board to get people to practice this. What's the thought that's faulty? What's wrong with it? Why is this not a good thought? What's the evidence that's true? And what are some of the new statements that challenge faulty thinking? This takes time and practice. One thing is, we had mentioned on a number of occasions teaching skills to help manage disorders. What that means is people need to practice. You just can't teach concepts and have people just take it through osmosis and use it. You have to actually let them practice this over and over and over. And this is why a lot of programs, even you look at programs for methamphetamine or stimulant addiction like the Matrix model, they all use homework assignments. They get people to do things. You want to work your patients. And it doesn't matter the disorders. You want to get them to practice whatever it is they're working on. Now, we had talked about this before, so I won't go into the details, but an important area is transitioning from a higher level to a follow-up level of care. You could spend a lot of time, effort, and money treating someone in a residential program, a detox program, or hospital. If they don't follow through, there's a significant chance they're going to end up in a high level of care. And this is where the motivational counseling approaches or the case managers for the chronically mentally ill are very important to help with that transition to follow-up care. And this is just some data from one of our studies where the co-occurring have more DSM diagnoses, more hospitalizations, more days in the hospital. If you add rehabs and detox, those days go up. So the P plus or the co-occurring, the P minus is psych only. So you see differences in terms of numbers of diagnoses, hospitalizations, and days in the hospital. If you look at aftercare, following up, same thing, you see big differences. The co-occurring group, they don't enter treatment as much, they don't attend as many sessions, they don't complete 90 days. And from all the NIDA research, if you have a drug problem and you don't get at least 90 days in treatment, you're not likely to benefit much. So here you have the people with the more diagnoses, the more problems, the more impairment who need treatment the most, the least likely to use it. So that linkage is important, getting them to make their appointment, and then once they're received by the ambulatory program, keeping them in. So we already went over some of this before. Now, we have one of the big issues with a lot of clients is how do I manage my emotions? And Dr. DeWay, he's going to talk about this briefly. This is something we could actually spend hours and hours on. Two things. One is, how do you manage some of the emotions in recovery but what's the difference between having the emotion and a mood disorder?
This is, as Dennis mentioned, this is very much of a fundamental part of the dual recovery principles. And when we talk about really emotional regulation, we're talking particularly in patients who struggle with substance use disorders, also in patients who have co-occurring disorders. You can imagine the emotional regulation is really much more really problematic. And particularly when we talk about patients who have been struggling with a lot of these emotions, the negative emotional states, that also in addition to being in mood states, which are really more prolonged states of severe depression, anxiety, or at the time when they are really having severe episodes of psychosis. And that can obviously, as I mentioned earlier, complicate things more and more in terms of management of the two disorders. And this is really very much well established, and you're all familiar with that, is that these negative emotional states by themselves are really in a way the number one triggers to substance use disorders. And these negative emotional states could be also a part of these psychiatric disorders. They could be a part of really whether the depression, personality disorders, anxiety disorder, and psychosis. And other really negative emotional states under the whole rubric of negative emotional states, you have also the boredom, the emptiness, the anger, the grief, the losses. I mean, there are a lot of these things that could also generate a lot of these states of people, particularly, there's the guilt and the shame that a lot of patients who have substance use disorder suffer from, are also patients who have co-occurring disorders, and also the most really difficult also for patients to deal with when it comes to the negative emotional states are really basically being labeled, stigmatized, and all these kind of things can really worsen the emotional state, can make them obviously feel much worse and can make it much more difficult for them to really deal with. And as I mentioned, the negative emotional states are as really fundamental to the relapse. In a sense, they are really a major contributing factor to the relapse, whether relapsing in terms of psychiatric or whether relapsing in terms of the substance use disorder. And always never to forget the fact that some positive emotional states are really interpreted by patients as really leading to that sort of a thinking that because I'm really feeling good, I deserve, for example, to have a drink. So always keeping in mind that these positive also emotional states could be potentially sometimes dangerous, depending on how patients perceive them and how patients process them. And as a big part of the dual recovery counseling and principles is really being in treatment, involvement in treatment that would look at the emotional regulation part, and that would really also very much tied also to being in treatment and addressing and adhering to the medication, because also a lot of the medications that are used for particular psychiatric disorders have this positive impact on the emotional regulation, and particularly also on impulsivity. This is another one that we see a lot in patients who have substance use disorder and patients who have also co-occurring disorders. This is extremely important when it comes to the anxiety, the social anxiety that a lot of patients, and it's unfortunate because it's that what we see is not really regularly and routinely assessed, because we always really assume that we make recommendations to patients about getting involved in groups or attending self-help programs, and really assuming that patients feel very much comfortable opening up and sharing and being comfortable that in fact, the social anxiety could be extremely paralyzing for these patients and could really, in a way, prevent them from being engaged in treatment.
Yeah, we did a study of 144 outpatients, and a third had high levels of social anxiety. And the reason we put this slide up is that addiction and co-occurring programs are highly reliant on group treatments, and these are folks that they won't tell you they're anxious about groups. They just won't show up, or they'll miss, or they'll go to meetings, and when someone says read the 12 steps, they'll freak out and they won't go back. So, okay, another area of intervention is to help people with relationships and support systems, and some examples will be helping the co-occurring patients develop a network. As we know from just good outcomes in medical diseases, psychiatric illnesses, addiction, or even in life, people with good support systems tend to do better. So we have to help people develop a support network. But very importantly is how do you ask for help? And professionals, we as a group of professionals, we're not good ourselves for asking for help or support for ourselves, but we expect it from our patients. We want them to go talk with people and get support and ask someone to be a sponsor, but we may have issues or problems and we keep to ourselves. So you can certainly understand it's not easy to ask for help, but that's a skill we have to let patients practice. You know, who do you call when you're depressed and suicidal? Who do you call when you're feeling despondent? Who do you call when you need support and you want to do something because you're just bored out of your brains, you know, something like that. Another issue is what's the impact of the co-occurring disorders on the family? Should we involve them, providing support to the family? And then you'll have cases in which family members are going to need help in terms of engagement in treatment. And this may be to support the patient, but it may be for their own needs as well, and to get involved in recovery as well. I mean, I never meet with a family group without being impressed with the degree of burden and what they've been through and how many of them are trying so hard to help the individual with the disorders, but help themselves as well. And these are just some examples of adverse effects based on some of the studies we've done here. You know, big issue is emotional burden, which the majority identify as a problem. And then here's a study of psychiatric patients another group did. But what you could list these numbers, but what it doesn't convey is how awful it is for the family members affected by a loved one who have a combination of disorders. So think family, going back to one of the early slides, think family, because families are affected as well. We can help in terms of interpersonal skills and deficits, you know, relationship skills, managing conflicts, specific problems in relationships and how to address these. And you have, in some cases, you have people that have to start fresh with just one new relationship because maybe everyone they relate to, you know, they're getting high or they're negative influence. This is a big issue. The second most common factor in relapse is inability to manage social pressures to use, and these can be direct or indirect. Someone offers you something or you're just around others. So we have to look at what are some high-risk activities and events, what are high-risk relationships, and early recovery romances too. People, you know, we've had, I'm sure many of you have seen people thrown their recovery out the window because they've got involved in someone and that relationship became more important than the recovery. This is just human behavior that we're dealing with. You know, 12-step programs, steps 8 and 9, talk about making amends. This is for people probably later on in recovery when they have some stability in recovery to address some of the adverse effects on other people, particularly families. This is very important, mutual support programs, because treatment resources, you know, we have less and less of these because of fiscal issues and regulatory issues and approval from insurance companies and so forth, so mutual support programs. And typically it's good to talk with your clients about what are their views and let them talk about what they don't like. What are some of their perceptions and experiences? You don't want to start out with, you know, what's positive about these programs, what can help. Let them talk about any kind of negative perceptions, and then you can deal with that stuff. Then you can talk about how they might help. Facilitating a linkage, it's good if you have people in recovery who can volunteer to take people to meetings or to come in and give talks to your groups of patients about the different kinds of support programs. Active involvement, those of you involved in the stage 12, you know that the outstanding review of Dennis Donovan of all the studies on stage 12-step involvement is that people who get involved, who go to meetings, get a sponsor, work the steps, they tend to do better. But very importantly is to monitor attendance and involvement, or people going to meetings. Because what you often find is as attendance drops off and involvement goes down, that could be in some cases an indicator they're headed towards a relapse. And so these are just some of the examples. You have addiction, you have dual recovery, you have mental health, you have some general mental health support groups, Emotions Anonymous, Emotional Health Anonymous, Recovery Incorporated. You have diagnosis-specific, Schizophrenia Anonymous. Some of these programs you don't have in every state, so you have to look at what's available in your area. Plus, when you get into rural areas, you have fewer of these as well. Lifestyle issues as well. Looking at what are the high-risk times, looking at schedules, for example, treatment of mood disorders, and actually treatment of chronic mental illness, the idea of having regularity and schedule is important so that people have kind of some structure to their day so they don't, sleep till 1 o'clock in the afternoon and do whatever the heck they want. Leisure activities, this is a big issue for addicted people. Some of them have to learn to have fun without drugs or alcohol. Others, you have occupational issues. And with the psychiatric rehab, they often teach life skills and how to use community resources. It may be things like, how do you take a bus? How do you make an appointment to the welfare department or housing program? How do you budget? How do you deal with check day stressors? And trust me, check day stressors are a big issue for a lot of our co-occurring clients. Okay, then we're going to take the last few minutes, and Dr. DeWay, he's going to talk briefly about relapse and suicide. Then I'll finish by just a few comments on group treatments of co-occurring.
Yeah. So obviously a big part of the dual recovery counseling is the relapse prevention. And when we talk about relapse prevention, obviously here we're talking about dual relapse prevention in a sense. We're talking about relapse prevention for the psychiatric disorder and relapse prevention for the substance use disorders. And you can imagine how it is really very much challenging for patients as well as the providers, whether the psychiatrists or the therapists, to really deal with these issues. And the most important thing to keep in mind when it comes to the relapse for the substance use disorders is really the high understanding better the high risk factors and the warning signs, and really addressing what the triggers to the relapse, and really obviously doing whatever patients could do to prevent relapse, and always keeping in mind any sort of episodes of lapses that could happen is reframing them as learning experiences than really patients having sometimes a tendency to beat themselves up over that and feel more angry with themselves, ashamed and guilty, and getting stuck in that vicious cycle and taking it as they are really in a way they feel more and more guilty and they get more and more stuck and they continue in a way using. So in terms of really the big part of really when I look at the relapse determinants, the relapse determinants include negative emotional states, the cravings, the coping, all these issues that have to be addressed when it comes to the substance abuse. When it comes to the psychiatric disorder, which as we know, we've talked about that, they are very much tied together, is really, for example, looking at some better understanding, and I give the example here of the relapse in schizophrenia, patients who have schizophrenia and going through psychotic episodes, we know very well that the relapse is going to be determined by, most importantly, the adherence to treatment, and obviously what is really tied to it also the abstinence, because if they are using any substances, the use of substances themselves could really precipitate a psychotic episode and lead also sometimes to poor adherence to medications. So here what we're really talking about is that we can't separate necessarily. We can't say, okay, we'll work on relapse prevention for substance use and then we can address the other relapse prevention for the psychiatric disorder, because they are very much tied together and linked together, and working on integrating them together in a sense and coming up with strategies to prevent and reduce the relapse risk when it comes to the psychiatric symptoms as well as the substance use problems. And one of the things that is really important, I'm going to give you an example of really the depression and patients who have alcohol use. There are a lot of also medications that can prevent relapse. And patients who take medications, for example, for the alcohol, the anti-craving medications, I'll give you the example of acamprosate or naltrexone, they could really also reduce the relapse risk. If the relapse risk is reduced when it comes to substance use, they could focus more also on addressing their depression. Moving to the quickly, and this is an important issue with the suicidal risk that, as I mentioned, is really amplified in patients who have the co-occurring disorders. Always remembering when patients engage in any sort of overdoses or any sort of behaviors that have been labeled sometimes as suicidal that might not be, that could be really impulsive behavior, is to always look at what we call, in a sense, the pathophysiology of that behavior and understand how much of it is really full-blown suicide attempt, how much of it is impulsivity, how much of it is under the influence of substances, but obviously keeping always in mind that patients can engage in a lot of behaviors that unintentionally could lead to potentially catastrophic consequences. So it's always really important to really assess that and to aggressively address it and understand obviously what it is, the behavior, and deal with it. And again, it's always important, this whole aspect of really working with families and significant others, that would definitely be a major part of understanding patients' behaviors, whether, as I mentioned, suicidal or impulsive behaviors, and always really coming up with an emergency plan on how to really handle suicidal tendencies and behaviors. Okay. Again, this is really always keeping in mind that any suicidal or impulsive behaviors could be part of the relapse on either substance abuse or the psychiatric disorders, and always remembering that what I mentioned earlier about the importance of the warning signs and identifying high-risk situations. And we know very well if this is really addressed very aggressively, that could lead to reducing the risk of engaging in suicidal behaviors. And yeah, that's it.
Okay. All right. I'm just going to make a few comments about group, and you'll have some slides you can go over. It gives a couple samples of structured group sessions. So those would be the psychoeducation, the therapy, and the family groups. Okay. I'm not going to go over this. If you look at SAMHSA TIP, these are the types of groups. They divide a little bit differently. The therapy groups would be the process. Support groups would be the mutual support groups in the community. And then CBT, or relapse prevention groups, are often called cognitive behavioral or skills development in the psychoed. So really, I think the point is group programs have to use a variety of different methods. In terms of the structured groups, what we have found, and we started this 20 years ago in the Cocaine Collaborative, and we've used this model where when you use structured groups, and if you look at other models too, you'll see the same format to a large degree, which is you have a topic of recovery theme, something related to addiction, psychiatric illness, or both. It could be relationships, it could be anger, it could be depression, it could be 12 steps, it could be family issues, it could be cravings. And so you have a topic or a theme, and you want to have a couple set objectives and a purpose of the session. You want to have major points to review, and you could take some topics like depression, and you can review them in several different sessions because there's so much to cover. But part of it depends on how many sessions you have. So you should have a core program. If you have 35 groups over 4 weeks, you want to make sure that you offer a core program. These are the 20 that everyone get, and these are the topics that will be based on what are the needs of this particular cohort. What are the methods of covering material, and then check in and check out procedures. And I want to talk briefly about some of the different methods, and I think we'll end on that. A few other things, I'm sorry. One is when you run groups, you have to be focused. I've watched a lot of videotapes, and what happens is clinicians always go all over the place, and they don't stay focused sometimes. They spend too much time going on tangents because clients or patients will take them that way. You have to be focused. You have to be flexible because sometimes you have to go on a tangent if someone's suicidal or some major issue comes up. The other thing is focus on solutions, not just the problems. I've seen too many groups where hour and 15 minutes will be talking about the problem and then 10 minutes on the solution. Make members work, get everyone involved. We typically, in any kind of structured group, we ask people to share. We even do this in supervision with residents and professionals. What's one thing you've learned or one thing that stood out? And it's interesting because then you get a sense of people's insight and paying attention to what's being covered. So in general, you want to connect the different disorders, substance use and psychiatric. You want to focus on the triad of thoughts, feelings, and behaviors. And then you want to shift to group process. And by that I mean things like, let's say you're having a group and nothing's going on, people really aren't sharing. Then you could make your observations, or people were not paying attention, that sort of thing. You can get into discussion about group process. And then the last thing I wanted to mention about groups, and then we'll take the last few minutes if you want to have any kind of questions, is what we have found is that when you're running a group program, you really need a lot of strategies, and we call these action techniques or experiential techniques. And one is in traditional addiction treatment, there's a lot of lectures. You know, you give a lecture about step one, or you give a lecture about addiction as a disease. We stay away from that. We like to do interactive discussions. And what you can do is you want to present, you can give lectures, many lectures. You know, you might talk for 8 or 12 minutes on a topic, but you want the patient to relate to what you're talking about. So if you're talking about addiction as a disease or types of depression, recurrent versus single episode versus dysthymia, you want to get them to relate to the material that you present. Videos are very helpful, but do not use these hour-and-a-half, hour-long videos where you babysit. What to do is use brief videos for specific reasons that sort of point out a issue and helps get the people involved in the discussion. A big technique is behavioral rehearsals, setting up role plays. The role plays can be anything from how do you say no when someone asks you to go drinking or use cocaine? How do you ask for a sponsor? How do you ask for a date? How do you talk to your boss about a promotion? Anything related to some interpersonal situation. We often assume if we talk about something it'll happen, but it's not true. A good example is asking for help. Patients will by and large agree that it's good to have a support network and you should rely on other people, but they don't know how to do it, so you have to teach them. Monodramas, that's sort of a Gestalt technique where you can take any theme, you know, it could be something like addiction, and you have someone externalize their addiction. They can sort of give it they can describe it, they can give it a voice, they can actually have an interaction with their addiction or their depression or whatever. Written materials and assignments, creative media, and we found too is we've used some PowerPoint slides, and I just wanted to mention this. When Dr. Dewey and I have a nice talk we give patients called What Research Tells Us About Addiction Treatment and Recovery. And we use some of the NIDA slides that shows the brain and this sort of thing, and it really captures their attention. And I think the point in all this is what patients don't like is if it's always the same person talking and lecturing over and over again, or always the same discussions. You really need a variety. It's no different than us using a variety of strategies to learn. So, okay, well, with that, I'm going to end, and we can take, Liz, if you have any questions. I'm looking on here, and I can't get to the questions written, but if there's any last-minute questions anyone wants to make before we end.
Sure. There's two questions in the queue. One is from Mariella Michelle, who's asking, how fine-tuned is treatment for particular psychiatric disorders such as post-traumatic stress disorder groups and attention deficit hyperactivity disorder groups?
Sorry,
What was the first part of the question?
What was the first part of the question?
How fine-tuned is treatment for particular psychiatric disorders like PTSD and ADHD?
In the context of patients who are abusing substances, or in general, just treatment of PTSD and ADHD?
I think in general.
Okay, well, I mean, I'm not really sure here whether we're talking about pharmacological treatment or psychosocial treatment or a combination of both. Obviously, I can speak about the pharmacological treatments. We definitely have pharmacological treatments that we use, you know, for patients who have PTSD. And obviously, we have high rates of depression in patients who have PTSD that a lot of patients can really definitely benefit from, really the antidepressants, you know, and particularly the SSRI. And with the ADHD, we have the whole range of stimulant as well as non-stimulant medications that we can use. I mean, in the context of patients who have substance use disorders, we have to be extremely careful when we're treating patients who have ADHD, you know, and they have a history of substance abuse. In terms of the use of stimulants has to be really done in a very cautious way. Not that we don't really prescribe sometimes, but I think we need to be careful about the potential for misuse and abuse of these medications, and basically going through the route of probably the non-stimulant medications.
Yeah, the other thing, and that's an excellent question, that if you look at the literature and the models, the attention deficit has not been given the attention that bipolar or PTSD has in combination with substance use disorders. And some of the strategies for addiction, like helping people organize their lives, they can help with attention deficit, but you also have interventions specific for attention deficit disorders as well. So Liz, you had one more question?
I have one more coming up.
Okay.
Earlier in the talk, Dr. Dewey, he mentioned that Hep C could be linked to mental health issues. Is that correct?
Hep C?
And if so, can you say more about that?
Okay. Yes. This is really very important. The hepatitis C does have an impact on the central nervous system. And obviously it depends on the stage of the illness. And what we've seen basically with the Hep C is patients having there are some cognitive changes that patients can go through, particularly attention problems, concentration problems, what we call the executive functioning problems. So in a sense, the Hep C itself can, when it affects really the brain, it can cause some of these cognitive effects. And also we know very well, and it's well established, also that the Hep C itself can affect the brain to a point where you can also have psychiatric symptoms such as depression, fatigue, anxiety. So it is really, we have more and more studies that have looked at that, and keeping in mind in patients who have Hep C and substance use disorder and psychiatric disorders, there is a potential for the impact of the Hep C on the brain to be much worse. And this is similar, in fact, to the HIV that also affects the brain and can really be contributing to a lot of the psychiatric and cognitive problems. And I can tell you, if you're really interested, I can send you, we have a review paper that we've published 3 years ago on the psychiatric and neurological aspects of hepatitis C and HIV. And Liz, I can send you basically the link, and you can share it with whoever is interested.
Great. I'd love to do that.
Mm-hmm.
All we have for right now, unless somebody has a question. If you do, I encourage you to press *1 now.
We do have a question coming in over the phone. It's from Mary Mitchell. Mary, please go ahead.
Oh, I'm sorry. I'm going ahead. Can you hear me?
Yes.
Yeah.
Oh, sorry. I was really trying to clarify the very cryptic question I had asked previously, in that how fine-tuned do you have to be in addressing specific psychiatric disorders in the context of perhaps a large substance abuse treatment program that would have a wide variety of people with various comorbidities?
Yeah, in a sense, that's really much clearer now. I appreciate it. I think it's just how do you, in a way, manage, to see if I understand the question correctly, how do you manage particular specific psychiatric disorders in the context of really treating more dual disorders and, in programs? I believe this has to be done on an individual basis, and it has to be addressed as a team by the psychiatrist and the clinician, and come up with particular strategies that have to be relevant to that particular population, particular patients. And I'll tell you, we have a lot of patients we see here with different varieties of problems, particularly ADHD and PTSD. And unfortunately, the groups or some sort of the treatments that we have here, the partial program IOB, does not particularly address these problems. I believe they have to be really identified and addressed in an individual setting on one-on-one, because we know clearly that there's going to be more general principles of treatment are going to be addressed in the group settings, and with particular situations like that, they have to be addressed more on one-on-one, and particularly when it comes to addressing the medication piece as well as really other psychosocial treatment. And I'll tell you, we've had patients that we referred from our programs here to specialized programs, for example, DBT, or where they would need more specialized treatment that we cannot really provide here for their psychiatric problems. And we've collaborated with other treatment programs within our system, and it works out very well.
Thanks, Antoine, very much.
You're welcome.
Well, thank you all.
Dennis, I have one more question in the queue.
You do? Okay. All right.
This is from Edgar Weiss. What to do with addiction counselors being used in some clinics that have fewer credentials in this fiscally constraining times, who have dealt with more complicated patients such as these co-folks? How can you really support them effectively?
Well, I think that's a good question, because In the mental health side, most clinicians have at least a master's degree. In the addiction side, that's not always the case. I think a couple things. One is that it's extremely important any clinician in whatever setting have access to clinical supervision, case consultation, group consultations if they're doing group programs, and if you're talking about co-occurring psychiatric illness, they have to have access to psychiatric consultation as well. And because I've seen residential assistants, non-degreed assistants, be spectacular in managing co-occurring disordered patients. They have a different role than a clinician. So a lot of it has to do with their knowledge and skills, but also what they have access to in terms of supervision and consultation. And the other thing, too, is people shouldn't be asked to do what they can't do. So if you feel like you can't work with someone who has schizophrenia and addiction, that's okay. You just have to be in a system that supports that.
Questions I have in the queue right now. I want to thank everybody for joining us today. I want to particularly thank Drs. Staley and Dwayhe for presenting for us today. I want to encourage everybody to mark your calendar for upcoming webinars. October 12th, we will be presenting on informed consent. December 7th, we'll be taking a new look at the Manual of Operation Procedures. So if you mark your calendar for that, you'll see invitations coming out shortly. If you happen to know somebody who missed today's webinar and they want to try to download the recording, it will be available on the dissemination library as well as on LiveLink. Thanks very much for joining us today, and thank you very much, Drs. Staley and Dwayhe.
Thank you.
Thank you, everyone. Thanks, Liz.
Thank you, ladies and gentlemen. That concludes today's conference. Thank you for participating. You may all disconnect.